Welcome to TCNtalks, an Anatomy of Leadership. We continue our conversation with Kim Brandt. In Part 2, CMS Leader explains hospice fraud, Medicare risk, and the future of healthcare. And now, here's Chris Comeaux.
So, Medicare Advantage growing throughout the country. And then we had the value-based insurance design, and there was a lot of discussion, and we had kind of an experiment period where hospice was carved in an experimental basis. So do you think that the hospice carve-in via the VBID may come back around? Were there some good lessons learned from the demonstration project?
It's been an ever-evolving thing, if you will, right? So under VBID, hospice was carved in, as you mentioned, and the plan became responsible for paying the hospice provider and coordinating all the care, both curative and palliative. That was, sort of the goal of that whole thing under at least the VBID model, and that was the way they were hoping to be. But as a result of it, I think we did learn some good lessons as a result of that, and I think, the demonstration gave us some good lessons learned about sort of, how good you could be at in-care coordination. I think there were some concerns about administrative burden, some of the payment pressures on hospices, and then some underutilization issues that were also raised as a result of that. So I think at this point, our team is really trying to figure out, all right, what is it that we should do. I think, some of the concerns and the tensions were, sort of whether or not the MA plans were incentivized to reduce costs for some of that. And, hospice is obviously it has a lot of costs later in life as a result. I think there was also some concerns about large versus small hospice providers because the larger systems could negotiate with the MA plans and the smaller hospices had trouble getting contracts and maintaining the margins, which was a little bit of an issue. And then there were also some administrative issues that came up, such as, concerns about billing variation and less standardization under MA than there was under fee-for-service. So those are some of the feedback that I got from our team as I was researching your question, because again, that's a little deeper than I normally go. But I mean, at the end of the day, I think they're still trying to figure out, was the lessons learned enough to make it a more permanent policy change, or is it something that we just want to say we learned from it and move on?
Gotcha. So it sounds like jury's still out.
I would say the jury is still out. Yeah.
Gotcha. We do have a podcast coming out with a CEO of a company who's actually, she and I kind of debated it. I am not for the actual VBID carve-in because I do think hospice is different. Right. It's so hard for people to choose it. One of the most alarming things in the data that I saw, Kim, and I think this alarmed the insurance companies, is the family. I'm going to overstate this, but the family almost felt like the insurance company was the death panel. Like they didn't trust the insurance company to make the referral to hospice. And then the insurance company was kind of stuck, like, how do we make these referrals? So there weren't good referrals. The length of stay wasn't good. And, these insurance companies are spending a lot of money for healthy aging marketing.
Yeah.
And that could concern them that if then they're the one responsible to make that. So to me, hospice is so different that it would make sense to keep it outside of the carve-in, but that's my 2 cents. We've got a podcast where I debate it with a lady who's very well known about it.
I'll have to listen to that one. I mean, from what I was able to gain from doing some quick recon on this, I would say that it was definitely not overwhelmingly conclusive from our side that this was something that should be, but they viewed it as a valuable takeaway in terms of good information to help inform how we make policy decisions in this area going forward. But I agree with you. I mean, conceptually, the Kim Brandt personal opinion, not that of CMS, is that it is a distinct type of service. And to me, it doesn't make sense to carve in, but I am not the one making that call. So
understand. Well, Kim, let's talk about something that you guys have just been incredible on, which is the waste, fraud, and abuse. So talk about, I'll give you the mic for a little bit. Talk about some of the work you guys have been doing, because you've been doing some pretty big stuff, making a lot of national headlines.
And Dr. Oz, if you follow his social media, follow it later this week as a teaser. You're going to see some big stuff starting Wednesday night through Friday. We've got some big stuff happening. But yes, I am super excited about this. This is my 3rd tour at CMS. And the reason I decided to come back was because not only is Dr. Oz incredibly persuasive, sensitive, as you can imagine. But also, he agreed if I was to come back, I said, I really want to tackle waste, fraud, and abuse. I don't feel like we've ever gotten it right. I feel like there's a lot that can be done differently, and I'd really like to go big on it. And then not only have we done so at CMS, but now, as you probably saw last week, the vice president kicked off his new fraud task force, which isn't just healthcare fraud, it's fraud against all government programs, which is amazing to have that kind of focus from the highest levels of government, if you will. But then here at CMS, we have just been going gangbusters. Literally since the moment I hit the ground last year, and certainly since Dr. Oz came in April. So a few of the things that we have done, the very first thing we did, which is one of our biggest accomplishments, was set up a war room. It's called the Fraud Detection Operations Center, or the FDOC. And from March 31st to December 31st of last year, we stopped $1.8 billion in suspect payments for just high-risk providers. So a very small number of providers, but providers who showed up on our radar real time before the claims were paid. Like, as claims were coming through, we saw them. We were flagging about 5 providers a day, which I know doesn't sound like a lot, but actually, given their volume, it was a fair amount. And so we were, going through and reviewing these, and as a result, we stopped 1.8 billion. 1.5 billion of that was related to durable medical equipment, DME, things like oxygen, wheelchairs, CPAPs, etc. So that was a big part of it. And then about another 100,000 or 100 million, I'm sorry, was labs. So it was laboratory stuff. So hospice was not one of the areas in the FDOC that popped up, but it was something that we were seeing certainly across the board. And then since then, the FDOC, as of today, has actually stopped 2.2 billion, and we've been able to kick almost 400 providers and suppliers out of the program. And so that is a significant amount of money saved to the program, and a good number of the people that we were able to kick out that just weren't good partners. So let's talk about hospice in particular. LA County, everybody knows, is kind of the epicenter of all of this. But as people were getting shut down there, or as people were getting more scrutiny there, they were starting to move and are starting to move. California to Arizona, California to Nevada, California to maybe Texas. It's definitely been a migratory pattern. That's part of the reason that we were visiting the hospice in Las Vegas earlier this year, because of the fact that we were talking to the Nevada folks about the fact that they've seen a 7x increase in the number of hospices in Nevada just in the last decade or so. In LA, it's been an even greater increase. There's now just in LA County 1,800 hospices that are listed. That's 4.5 times more than the number of Starbucks in LA, just to put it in perspective. And so as a result, we believe that upwards of 900 to 1,000 of those are just completely false. So almost 50%. And so our team has been extremely focused on going and looking at them to suspend, which means that we suspend payments. They no longer get paid by Medicare, or revoke, which means that we just kick them out entirely of the program so that they cannot bill anymore. We've been great partners with a lot of boots on the ground people out there. Sheila Clark, who works for some of the hospice advocacy organization, the Senior Medicare Patrol, other partners have been just super helpful in helping us to really look at what's happening. But unfortunately, a lot of this is due to organized crime. These are people who, foreign entities buy sham operations, set up things using stolen Medicare beneficiary identifiers, or they'll just go out and sign people up. One of the most common scams is to just send people to someone's door and say, hey, would you like a 40-inch TV? In exchange, if you sign this, you get a 40-inch TV, and we'll come by and you might get some light housekeeping or something like that. And instead, sort of like I told you with the six-pack example earlier in this episode, they get paid thousands of dollars a month, and legitimately the beneficiary doesn't get anything for that. And then when the beneficiary goes to actually get legitimate Medicare services, they can't get them because they think they're on hospice. And so getting any kind of curative treatment is not allowed because they're signed up for hospice. So we've also been sending letters now. We've sent thousands of letters out in California, Nevada, and Arizona to all of the people who have allegedly elected hospice. And we've had a high hit rate of people writing back and saying, I'm not signed up for hospice. I never agreed to be on hospice. But the fact is now we're double checking. So we're not only checking on the validity of the people who are there to make sure they're good partners, watching their billings, making sure they're actually legit, but we're also making sure the beneficiaries know that they're signed up so they don't have a situation where they go to get real services that they need, curative services, and told they can't.
Wow. Well, Kim, kudos to you and your team. I don't know if you know Dr. Ira Byock. He's written some amazing books, kind of like he's like the father of hospice in some respects. There's a lot of matriarchs of hospice as well, so he's not the only one. But he has written a book called The Strategic Path Forward for Hospice. But in that paper, he coined a lovely phrase. As you've already learned, the majority of hospice people are just kind, caring, beautiful-hearted people. But he said collegiality ends at criminality. I've known about some of this stuff for a while, and it's like, why is no one doing anything about this? And so kudos to you guys that you are doing something about it. So this leads to my question, and it kind of goes back to that, provider number thing. And so a lot of the nonprofit hospices have larger programs, and they don't play that game of provider numbers. So if the outside audit firms are looking for a nice fishing hole, the fishing hole is bigger where you've got more patients per day. So it feels like sometimes they pick on some of the nonprofit providers because when you look at those provider numbers, well, there's just 30 patients a day, 20 there, but that entity might be aggregating those numbers for financial purposes. So they get to fly under the radar screen for the audit and we get picked on. So how do you make sure, because I love what you're doing, how do you make sure that the good actors don't get kind of inadvertently as collateral damage in some of this?
No, it's a great question. And we struggle with that all the time, quite honestly, because, you want to cast a wide net, but you don't want to catch such a wide net that we make it administratively burdensome or difficult for the good guys to be able to maintain. And one of the ways that we do that during normal sort of just routine business is to do what we call targeted probe and education, which means that we'll do an audit and we'll, do that initial audit. Maybe it's of, the care plan or whatever it is, on the hospice, and we'll determine if there are things that look right or not right. And then we go back to the provider and give them a chance to update it, to get it right. We explain the rules. We tell them what they need to know. They have a chance to then resubmit, sort of like a teacher says, it doesn't seem like you really got this right. Why don't you take another try and send it back and we'll give you maybe a better grade. Sort of similar to that. We give them sort of the redo. Then if they don't get it right after that, then we give them one more try, but we're a little more serious about it, saying, okay, you really need to get it right this time. So it's kind of your third try or you're out, so to speak. And so on the third try, if they haven't gotten it right after two series of education and things like that, that's when we really go hard and actually, really double down on going after the money. So the way it should work with legitimate providers is they should have sort of a multiple try sort of thing. They shouldn't necessarily get dinged, right away. We try to work with them. We try to work through the education process. And then sometimes they don't know that they're affiliated with bad entities or bad actors. And so sometimes we have to sort of then, some of these legitimate hospices have a medical director that might be associated with some people that are bad actors that they don't know about. And so sometimes we have to really work with those legitimate providers to be able to say, hey, you might want to reconsider your working relationship with some of the people you're affiliated with, because those affiliations could be tainting them by association as well. So we always try to give the benefit of the doubt. We always believe in due process. But the fact of the matter is that in some cases, particularly in hospice, durable medical equipment, and some of these other high risk, high fraud areas, we're occasionally going to catch some good actors. And we try really hard to make sure that we get them out and get them back right when we do. And my best advice is when that happens, come to us. If you're one of those people, you need to come to us. You need to let us know, hey, raise your hand. Our contractor might be focusing on them because we've told them to focus on people that have certain discharge rates or certain, other characteristics. Let us know, and then we'll hopefully be able to get it squared away. If you're actually doing things the right way, we'll have an independent review done, and hopefully we can get you back and out of the net, if you will.
Perfect. So Kim, now go back to maybe looking out to the future. So many hospice leaders are maybe a little concerned, but more anticipating where is federal policy heading. If you were giving advice to hospice executives today, what capabilities or strategic shifts should they be thinking about as they prepare their hospices for the future?
I think some of it is what we already talked about in terms of the fact of the matter is, I think the future of hospice is definitely more from that Medicare defined benefit at the very end of life to more sort of a broader, managed and earlier stage care model, if you will. I think it's kind of, thinking about it in a little bit different way. Again, not knowing exactly what we'll do as a result of the VBID and things like that. I'm not going so far as to say that, VBID is going to do it, but I think, the fact of the matter is that there's going to be a little more of a shift towards, I would say, models that support both treatment and comfort, sort of that curative and palliative a little bit. And I think people are going to be very, very focused on analytics and data. As I said, we're getting more into that. I think people are going to need to be looking at length of stay by diagnosis, live discharge rates, CCN, cap exposure, like we talked about before, referral patterns by source, the cost per patient versus reimbursement overall. Those are all things that I think we are becoming much more data driven. Like I said, we're trying to use data to drive quality. I think that hospice providers and frankly all providers in healthcare are going to have to become much more data centric as well, because that's just the future and that's where we're going. So I think it's a little bit of a mind shift in terms of broadening the mindset of what is hospice now, because I think what is hospice is going to shift a bit. Like I said, it's going to be a little more of, I think, a longer, not just your last 6 months, which was, we've now learned thanks to this episode, is not something that was ever set, but it is now sort of thinking about how it is that, you can think about that. And then I think also it's that, how do you think about palliative care, and what does that mean, and sort of where does hospice fit into that overall?
Yep. So we brought you to our Teleask network. You did a great presentation in PHI. You came and talked to our network. And in that meeting, you mentioned a chili cook-off, but in the context of technology. And I made a note. I'm like, if I ever get Kim on my podcast, I'm going to ask her, what the heck is a chili cook-off related to technology? Can you talk about that?
Yeah, I'd love to. So the chili cook-off was kind of my idea. We were thinking about it more as okay, how do we get a bunch of people to get together and determine who has the best thing? And so we called it a chili cook-off, and some people got way into it. We even had like hot sauce and everything. But what we had was 250 plus tech companies that all came together. And what was really cool about it was they all brought their best machine learning, AI, other types of approaches to how they would help combat healthcare fraud. Like, what were the things that they thought could really help us at CMS move the needle in a sustainable way? And the reason it came about was because in my first, let's say 6 to 8 months here, probably 8 months, here at CMS, I met with over 100 different vendors, every single one of whom claimed they could save the program $2 billion or more. And I would love it if that was the case. And I'm sure many of them actually thought they could, and maybe they could have. I honestly don't know. But I didn't know. I did not feel like I was the one that could make that call. There was so many options to choose from, like a real chili cook-off. How was I going to determine who the best one was and where I was going to get the best dollar? So we had MITRE Corporation, who is one of our contractors, go ahead and just basically independently analyze all the proposals. They picked the top 10. The top winner was Milliman Inc. They won with a really creative proposal that was kind of innovative, and we're now pilot project with them on that. But what's really cool is you can go on our www.cms.gov/fraud. So again, cms.gov/fraud. You can go there and you'll actually see a white paper, which I think posted last Friday if all went well. But there's a white paper that summarizes what we found, talks about the top 10 submissions, and kind of gives you more intel. But the whole goal of this was to really help us find out if there were things that we were missing, or if there were approaches that we should be thinking about. And what we found was we were aware of most of what was out there, but there were creative and unique ways of using a lot of that technology, which we hadn't really thought about. And so it really opened our eyes to sort of what was out there. And our hope in issuing the white paper is for those who don't have the resources, money, or time to do a 250 plus entity cook off, if you will, this will give them some good information to be able to help them as they think about what tools and resources could be useful to them. So we loved it. I think you're going to see more. We just had a provider directory bake off. We love food here at CMS. So who knows what we'll have later this year, but I'm hopeful we'll be able to do another round of it this time on Medicaid tools because we're really focused on Medicaid program integrity now, and I'd love to be able to see what works on the Medicaid side. But it was really great. I'm very excited by the outcome of it. Congrats to Milliman. They did a great job. But more importantly, it helped us to really think very closely about what tools we're using and what tools we need to use to be able to keep crushing fraud.
In our show notes, we're going to include a link to that white paper then, Kim. So last question to you. When you step back from all the regulatory stuff, what do you hope hospice looks like in, let's say, 15 years from now?
It's a great question. I think for me, what I hope hospice looks like is a sort of merging of the experience I've had between my family members. So I would love it so that if someone so chooses, like my mom did, to be able to die in their own home or has the luxury of dying in their own home, that they're able to do that with medical professionals who can help provide the family with the tools and resources needed to be able to help that person die with dignity in their home, but also help them understand the dying process and what's needed to help manage that and help them do so in a as pain-free and sort of comfortable manner as possible. I think, some of the challenges of being in a facility are you can't control the environment, you can't control, when and how pain medication is always delivered and things like that. And I think those are some of the challenges we faced with my uncle when he was in a facility. They were wonderful people, but there were, it was not the most stress-free end of life, so to speak. And so I think what I'd love is whether it's in a facility or whether in a home, we all have an agreement as to, how to make sure that the people that are dying and their family members have the support and the resources needed to be able to help that person exit in as calm and just, stress-free environment as possible. And I think so many hospices, like I said, we went to the Nathan Adler Hospice, and it was really impressive to me what they were doing to really help those patients. That it was a beautiful environment. It was, really seemed like incredibly talented staff. That's what you hope everybody would have. You want to be able to have, it was almost like being in Hawaii. They had the palm trees, they had a lanai. It is a truly first-class
It is a
facility.
beautiful facility.
And I don't mean to keep calling them out, but it really struck me because to me, that embodies sort of what you want. You want to have it so that people feel that they are loved and comforted and are just able to go out in a way that pays tribute to the lives that they've had. So
good, Kim. Kim, final thoughts. You've got the ear of hospice and palliative care leaders. What final thoughts?
I think final thoughts are continue to engage with us. One of the best things that I have found over my past year now here at CMS, particularly because so much of it has been spent focused on hospice issues, is the more you tell me, the more we learn and the more we can make changes. And there has been such a great dialogue with the hospice community, particularly on the fraud and abuse piece of it. Again, I don't claim to be influencing things on the payment side. Dr. Oz does. He influences both. And the fact is, you have his ear. Use it. Continue to talk to him. Continue to talk to us. Tell us where you're seeing issues. Tell us where you're feeling the pain points, because Dr. Oz is very committed, as is Chris Comeaux, as is our whole leadership team, to making sure that people do age and die with dignity, and want to make sure that we are doing all we can from a program perspective to do that. My part of that is to get rid of the sketchy actors so people don't get caught up in that or have it so that they can't get hospice services because it looks like they already have. So I'm trying to do my part on that part. And then Dr. Oz and Chris Comeaux and the others are thinking about the payment sides of it. But the most important part of all of this is having that dialogue with us. The more you tell us, the more you influence with us through letters or just visits, or even when we come and visit you. That has been, I think, the most eye-opening. I mean, obviously, I've had personal experiences, but the interaction I've had with the professionals in your community has made a huge difference in how we've approached our fraud fight, but it's also really influencing how we're changing our thinking about hospice in general. And that's huge. So just keep it up.
Well, Kim, we're based in North Carolina. If you and Dr. Oz ever want to kind of make it down here, we have some amazing programs all over the country, but we've got a good conglomeration of them in the Carolinas. And so Carolinas are beautiful. So if you ever want to pay a visit down here, we could create some
keep
great.
it in mind. I have a feeling we'll be heading that way at some point over the next few months. So I'll definitely keep that in mind.
All right. And thanks for the work that you guys are doing, Kim. The fact that you took time for this podcast, thank you. I know how busy you are. I work crazy hours. I look like a slacker compared to how hard you and your team are working. That says the world about how much you care about what you're doing. So thank you for that. And I love how you guys have engaged the whole hospice field, wanting to make it better. And so that's a refreshing change. So thank you.
Well, thank you. We are so grateful to have you all as partners. And I hope to significantly reduce the amount of fraud, so we aren't talking about that anymore, and we can focus more on how we can do a better job of providing good care. That's the goal.
We don't want to, they're like so in at the bottom of the class. We want to be talking about this is what great care looks like.
Exactly.
Yeah, so you can eliminate that part. So, well, thank you again. To our listeners, we want to thank you. At the end of each episode, we want to share a quote, a visual. The idea is create a brain bookmark, a thought plotter about our podcast subject. This one's going to be a fun one. We want to further your learning and your growth and thereby your leadership, and we want it to stick like a brain tattoo. Please be sure to subscribe to our channel. We don't want you to miss an episode. We'll make sure we include a link to the article that Kim mentioned and maybe a couple other resources as well. You know, it's easy for us to rail against the world and be frustrated by things. Let's be the change that we wish to see in the world. So thanks for listening to the TCNtalks Anatomy of Leadership podcast. And here's our brain bookmark to close today's show.
The system we build today determines how we and the people we love will one day be cared for. By Kim Brandt. Thank you, USI, for sponsoring this podcast.